Welcome to The Debate. Today we're talking about probably the most discussed class of medicines in a generation, GLP-1 receptor agonists. You know them as drugs like Semaglutide, which is Wegovy, and Tirzepatide, or Zepbound. They were first developed for diabetes, but their powerful effects on weight and heart protection have just completely changed the game for managing chronic disease.
It's a huge moment in medicine, it really is. And these aren't just, small improvements. This is a major biological intervention. And that's exactly why we need to have a really frank discussion about balancing their incredible promise with their very real risks in the real world.
Right. So to set the stage, let's just briefly touch on how they work. GLP-1 is a natural hormone our bodies release after a meal. These medicines they turn up the volume on that natural signal. They act like a strong brake, slowing down how fast your stomach empties, which is, why people feel so full. And what I think is really elegant is how they tackle the whole sugar problem. They help the pancreas release insulin, and this is key, they're smart about it. They only do it when blood sugar is actually high.
And that amplification, as you call it, is the source of both their power and, frankly, their problems.
So the central question we have to wrestle with is this. Given the profound and now proven benefits of these drugs in fighting heart disease and obesity, should we be prioritizing wider, more straightforward access? Or do the really substantial risks and complications mean we need stricter caution and oversight?
I'm going to argue that for the people who qualify, the benefits clearly merit embracing this powerful medical tool.
And I'm going to focus on the seriousness of the side effects, the complexities the whole regimen places on patients, and the critical risks that come from improper use and, honestly, a lack of real patient support. Well, my position is really rooted in what I see as undeniable data. It shows these medicines are essential for specific high-risk groups of people. We're talking about adults and even kids age 12 and up with obesity or adults who are overweight and have at least one related health problem. And when we talk about embracing this, it's because the evidence is now literally life-saving. Semaglutide, for instance, is now specifically approved because it reduces the risk of major adverse cardiovascular events, what doctors call MACE. So that's, cardiovascular death, heart attack, or stroke.
And that's the SELECT trial data, a 20% reduction in MACE, which I'll grant you is a very powerful number, especially for patients who already have heart disease. That is a robust, long-term benefit.
Exactly. And it's not just about preventing that one single event. These drugs get at the whole web of interconnected health issues that are driven by excess weight. They consistently lead to very significant weight loss. Studies show an average body weight drop of nearly 15%. And that weight loss directly translates to improvements everywhere else. Big reductions in triglycerides, sometimes an 18% drop, and lower blood pressure. For people who have struggled for years, for decades to get control, this drug gives them the leverage they desperately need.
Okay, look, I'm sorry, but I just don't buy that the benefits so easily override the risks, especially for the broader group of people looking for treatment. Let me tell you why. While the effects on weight are transformational, the safety profile demands intense caution. The most common side effects are severe gastrointestinal issues. Nausea is reported by almost a third of patients in some of these trials, along with significant vomiting and diarrhea.
And those are known side effects, yes. But they're often managed by starting with a low dose and giving it time.
Managed, maybe. But they're severe enough that they caused a massive 16.6% of people to just stop the treatment entirely. That's compared to only 8% on placebo. And more critically, these common GI side effects can lead to dehydration, what doctors call volume depletion. And the risks go deeper than just discomfort. That dehydration has led to serious reports of acute kidney injury, the kidneys temporarily shutting down, and worsening of chronic renal failure. This is not a casual treatment. It is a powerful agent that demands some serious clinical respect.
So we establish the power here, but how do we weigh that MACE reduction, that long-term life-saving benefit, against the immediate and, yes, sometimes brutal patient experience? I still maintain that for that high-risk patient with existing cardiovascular disease, The ability of this drug to provide a statistically significant long-term protection against the #1 cause of death makes it an essential standard of care.
That's an interesting point about long-term safety, though I would frame the short-term risks a little differently. The consequences are systemic, and they sometimes require surgery. We have documented risks of acute pancreatitis, a very dangerous inflammation of the pancreas, as well as acute gallbladder disease. Cholelithiasis is the technical term for developing gallstones. And in the trials, these problems often required surgery, a cholecystectomy, to remove the gallbladder. Given these non-trivial, potentially life-threatening risks, doctors have to ensure patients are fully aware and strictly monitored, way beyond typical medication oversight.
The monitoring is high, I agree, but it's appropriate for the serious conditions we're fighting.
And that leads us directly to the practical reality of just getting these drugs safely and the complexity of dosing. These are prescription-only injectables. They usually involve weekly shots and require a very gradual dose escalation schedule over 4 months. You start low and ramp up slowly to try and minimize those GI reactions. But all that complexity, it just increases the risk of error, especially if patients skip steps or, even worse, they get them from unregulated places like aesthetic spas or off social media.
But see, that risk of misuse is a regulatory problem, it's an access problem. It's not an intrinsic fault of the medicine. The manufacturer's built in guardrails for exactly this reason. The dose escalation schedule is intentional. It's designed to minimize the very GI issues you're citing. And the pre-filled pens, they simplify the injection itself, making it manageable for patients who are actually following the instructions. The core requirement for success is still the drug combined with professional guidance on diet and activity.
But that reliance on diet brings up the need for real holistic care. We're not just talking about helping with weight loss. We're talking about managing appetite suppression that is so extreme it can actually become dangerous.
But the drug makes possible the kind of weight loss that patients often struggle desperately to achieve on their own. It provides a powerful tool that, when it's combined with professional guidance, lets them hit critical health milestones. In one study, 84% of people on the highest dose got to at least a 5% weight loss, which we know delivers huge cardiometabolic benefits.
Yeah, I see why you think that. I really do. But let me give you a different perspective. That powerful appetite suppression creates a real risk of unintended consequences, most notably severe protein and muscle loss, not just fat loss, if a patient's nutrition isn't meticulously managed. We've seen cases of denutrition and malnutrition reported. Healthcare teams have to constantly tell clients not to skip meals, even when they feel zero hunger. They have to encourage specific things like frequent, bland meals, just to manage the discomfort. It suggests the commitment needed from the patient and the support from the healthcare system is profound. It's much more complex than just taking a weekly shot.
I think when it comes down to it, we have robust data from massive, multi-year trials, and it shows a statistically and clinically significant reduction in major heart events and incredible weight loss. This tool is transformative for the specific patient populations it's indicated for, provided, of course, that they adhere to the prescribed lifestyle and dosing schedule. The benefit-risk profile is highly favorable when it's used correctly.
While the heart benefit is compelling, it is a celebrated breakthrough. The serious risks, the GI disturbances, the potential kidney issues, and the absolute critical need for safe acquisition and strict medical supervision, it all means this just is not a simple solution. The focus has to stay on managing these risks while making sure only the appropriate patients who are fully aware of the stringent requirements are the ones who get access.
The evidence really does illuminate a powerful new frontier in treatment, but it's one that I think we both agree requires meticulous, ongoing evaluation of benefit and risk on an individual basis. There is clearly more to explore in how we safely integrate these powerful agents into our broader healthcare strategies.